Here, a young child is 2 years old, clumsy when walking, often falls, knows 50 words, starting to assemble phrases, rest milestones are normal, asking for investigations. So, analgesia, no investigation needed. What do you think? So, what do you think about the 2 year child? How his development milestone present for the 2 year child? Okay, so first let's give it a look for 2 year. Okay, here. So, 2 year child, I have added the full file. You can read once you are studying. So, in the question, they have mentioned about the 2 year, like 24 months. In gross motor, this child walks up and downstairs 1 foot at a time. Please remember this. And visual motor, imitate stroke up so down with pencil, build a tower of 7 blocks. Please remember these things, okay? 7 blocks, and can remove clothing. And the language, so 50 words, 2 word sentences, follow 2 step commands, use pronouns inappropriately. So in the question, uh, our child is 2 year and knows 50 words. It's normal. Starting to assemble phrases. Yeah, that's normal. Rest milestones are normal. And there's only one more thing. Clumsy when walking, often fall. So what do you think? Is it normal or not? Yeah, they have mentioned walk up and down stairs 1 foot at a time. Okay, and the social adaptive parallel play. Okay, so let's check what are the red flags of these children. Okay, so for 2 years. Okay, here these are the red flags. You have to remember these things. Yeah, because that's why we are actually suggesting to book your exam in a later day because these are like repeating questions. Then you can like at least remember, as example, remember they have given 2 year child. So you can just like give it a read at least 2 year. I know this is you don't like this one. Even I didn't like this one because I was doing the exam. Yeah, but that's a advantage doing exam in the last days. So we know the age and usually the questions, age and everything can be repeated. Okay. So what are the red flags in 2 years? When playing with toys, tend to bang, drop or throw them rather than use them for their purpose, like cuddle dolls, building blocks. Okay, so communication, not learning new words. For 2 years, they should know 50 words and 2 phrases, sentences, like those things. Then not putting word together. Okay, so these are the red flags for communication and cognition, fine and motor, and self care. So in here, the red flags is does not attempt to feed self using a spoon and or help with dressing. Gross motor not able to walk up and down stairs holding on. So what do you think about this question? What do you think about this question? I know the question is not completed. What do you think? Type your answers in the chat. Just your opinion. Just need your opinion only. Yeah, type in the chat. What do you think about clumsy when walking? Often fall. Is it normal or not? Who is having like 2 to 3 year children in their home and they can tell? Yeah, it's normal, right? Usually the 2 year child is like a clumsy, right? So it can be normal because that's good. So you don't have to remember all the milestone, right, Dr. Bhagya? Even when we doing the like milestone session, some of my friends have like 2 to 3 year children, so they're like, we don't have to remember everything, we know from the experience. Yeah. Yeah, yeah, even it's very hard for me to remember these things because I don't like this milestone lesson. But the thing is, if they have us in the exam week recall, if this question is repeated in the exam, so then only then you have to just like think about it. Like as example, in November they have mentioned this milestone in 2 year old. So then if you are doing exam in day 5 or day 6, then you have this recall and you can just give it a look about this 2 year like motor communication, social and gross motor and visual motor, these things. Okay, like that. Otherwise I know it's very hard, but some doctors can remember like by experience, right? Yeah, so in that case, no investigation need. This child feels like a normal, right? Okay, so you can just give it a read. I know it's hard, but you have to remember at least some of them. Like usually, in AMC, they asking about the 6 months and 3 months, not every month. Like just some, you can remember some pictures. Okay, so next one is uncomplicated diverticulitis case, discharge home. Okay, discharged home. Now symptoms mild. Ask info management. Antibiotic sensitivity given. So here, intense, insensitive antibiotic, sensitive antibiotic IV. Observe and manage. So what do you think? Type your answers in the chat. I know the question is not completed, but you can think something, right? Yeah. Okay, some doctors go with 3. Other, yeah, most of the doctors, yeah, and one doctor go with sensitive antibiotics. So, what is diverticulitis? So, what is diverticulitis? Who can tell me? So, usually diverticulitis means there's a outpouching of the mucosal and submucosal layer due to the weaker colon wall, right? There's outpouching. Okay, so and diverticulitis also there are usually diverticular disease. Okay, diverticular disease is also divided by diverticulitis. It has some component. Diverticular disease has diverticulitis and there's a different names. Okay, so don't confuse. Actually, diverticulitis mean there's a inflammation, right? So these have two types: complicated and uncomplicated. So what does mean uncomplicated and complicated? So uncomplicated mean in here there's just recurrent persistent abdominal pain, but there's abdominal pain like usually left lower quadrant pain, fever, tenderness, leukocytosis, and these are like normal features in uncomplicated cases. And when it gets complicated, mean if there is a diverticulitis with perforation, abscess, bleeding, fistula formation, peritonitis. some obstruction, sepsis. So these are the things like in complicated diverticulitis. In here also they have mentioned patient with uncomplicated diverticulitis mean without any of perforation, peritonitis, sepsis, septic shock, and any associated abscess, okay, may not require. Here they have mentioned. Usually, for uncomplicated cases, they do not require antibiotic therapy. So, okay, so usually how we treat this patient? Usually we are doing the conservative management, but in some cases, like you have to remember these three cases. Like if the patient is immunocompromised, or if it is right-sided diverticulitis, or failure to improve after 72 hours of conservative treatment. Okay, conservative treatment. In these indications presence, then we have to think about antibiotic therapy, right? Um, Other than that, we manage uncomplicated diverticulitis conservatively. Okay, in our question, uncomplicated diverticulitis case, they haven't mentioned anything about they are immunocompromised, or already like after 72 hours from conservative treatment, or right side. They haven't mentioned anything about that in this case. So in that case, we can observe and manage, right? So there's no indication for the antibiotic. In here, if the antibiotic is needed in that for the uncomplicated diverticulitis, in that case, you have to give amoxiclav. Okay, augmented amoxiclavinate. You can give 12 hourly for dosage. Yeah, 12 hourly. Okay, please remember, if it is immediate delay hypersensitivity present, then we can think about the cefuroximine plus metronidazole. If severe immediate reaction is hypersensitivity present, then think about methoxol plus metronidazole. Usually only if there is a indication present. Okay, otherwise for the uncomplicated one, we are not usually giving antibiotic. Please remember this part. Okay, yeah. When okay, like when in mm, complicated diverticulitis, what is the choice of antibiotic? What is the choice of antibiotic for the complicated one? Who can tell me? You should know these things. For the complicated one, who can tell me for the complicated one, what is the antibiotic choice? Please, doctor, type your answers in the chat. Do you remember something? I call it gum. Today our question is uncomplicated one. Diverti. Yeah, you are correct, doctor. You should remember. Okay. Today our question is not about complicated one, but we should know about the complicated one as well. So I'll quickly show it. Okay, here is happening here. I don't know this STG is like how to remove. What is happening with my TG? There's some calculator. How to remove this one? I actually don't know. Let's come back again. Here, this is for here the empirical treatment for empirical antibiotic for complicated cases. Okay, here you have to remember Sure. Same thing we discuss uncomplicated one. This is a complicated one with perforation, peritonitis, sepsis, septic shock, or any associative abscess. Okay. So in that case, is managed with intravenous antibiotic therapy. However, oral antibiotic therapy may be appropriate for patients who have small abscess, example less than 5 centimeter in diameter. No other features of complicated diverticulitis and can otherwise tolerate and absorb oral therapy. So usually remember it as IV therapy. And I mentioned something here. If this abscess is small, abscess mean anyway complicated case. So abscess is small, still we can think about like less than 5 centimeter, think about oral antibiotic. Otherwise, we are giving IV antibiotic. Okay, so what is the standard regime for the complicated one? Here, empirical treatment for complicated diverticulitis without sepsis or septic shock as a three drug regime. Okay, three drug regime. Please remember main drug is gentamicin or tropramycin plus metronidazole or amoxicillin or ampicillin. Usually, they are giving this combination gentamicin plus amoxicillin plus metronidazole. That's why we remember it as gum. Okay, please remember this is another gum indication. Okay, as you remember, I already told in your study area there should be a gum indications, right? That means what are the like when we use these genta amoxi and metronidazole indications, because like if you are like comfortable with these things, then it's very easy to answer in the exam. Okay, yeah, just remember these things. If they are allergic, then we can give ceftriaxone plus mestra or piperacillin tazobactam. Like that, you can read it if you want. This diverticulitis full therapeutic guideline, I can send it. Okay, like after the class, please ask in the group. So you all agree with observe and management, right? Okay, so let's move to the next question because we have so much today. We have to be a little bit fast, right? Yeah. Then a pregnant woman, 36 weeks, currently smoking, no complaints, come to you. Height of uterus is 32. Next. So what do you think? Ultrasound of fetus, speculum examination, send home. So what do you think? What is the height of uterus that should be in 36 week? Type in the chat. Yeah. What is the actual length? It could be how we calculate it. Yeah, it should be either -2 or +2 to the gestation. Like that means the like a healthy baby, the height should be could be 38 centimeter or 34 centimeter. Okay, either 2 plus mean 38 centimeter, -2 mean 34 centimeter. Okay, but our baby is 32 centimeter. Sorry, -2 means 34 centimeter, but our baby is 32 centimeter. That means the baby is smaller than usual gestational age. In that case, what we should do? In that case, we have to do the ultrasound, right? Ultrasound of the fetus. Yeah, the same thing, 30 weeks pregnant. Yeah, the same thing. So in here, current smoker, that patient can be have fetal growth restriction, placental insufficiency, low birth weight. So in that case, first of all, we have to do the ultrasound, right? Because other things are like not appropriate, like send home, not good. We have to do something. We have to check other parameters as well. We don't know if there's a growth restriction or anything because our patient is having she's smoking, right? Yeah, like that. Okay, how to think like that. Have you like revised that intrauterine growth restriction part? Symmetrical one and asymmetrical one. I have explained. Have you revised? Have you revised? Please hurry up, doctors. Today we have not much time left, so we have to do it properly. Not yet, okay, but you will forget it, okay? I have mentioned how to draw this baby's head and the tummy, then calculate it like that, okay? It's like, it's not hard, but you have to like work hard to remember it, okay? Like that. Okay, so when can we see the symmetric, like the age, like which trimester we can see symmetrical intrauterine growth and asymmetrical intrauterine growth? These are the questions because I have repeated these things. Okay, so symmetrical IUGR, in which trimester we can see? You should know these things. This is very high for AMC. Like every month they are asking from this intrauterine growth restriction. Which trimester? Yeah, it's usually first or second trimester, right? Asymmetric one is third trimester. Please remember, okay? Yeah, okay. And when the patient is smoking, like there's a common cause as a smoking, that can eventually affect the asymmetrical intrauterine growth restriction, okay? We got one question in October. The this women is smoking, and then what is the what we can see in the fetus, like the answer is asymmetrical intrauterine growth, because symmetrical one it's happened in the early like T1 and T2. That's due to the chromosomal diseases or torch infections or the structural abnormalities. But in asymmetrical one, the third trimester one, usually due to uropresented insufficiency, maternal hypertension, preeclampsia, smoking, or malnutrition. Okay, so just remember. I just revise it again, but please, you have to watch that video, and you should like work by heart, okay, to remember it. Yeah, okay. Let's move to the next question. A woman, 48 years old, complained of hot flashes. She had a hysterectomy 4 years ago. Um, Again, they have, the record has mentioned the same thing. Then treatment, testosterone, estrogen, amitriptyline. So, what do you think? Mm-hmm. Is this postmenopausal or perimenopause? Yeah, because they have not mentioned anything about the postmenopausal, like end of the menstruation and the time. They haven't mentioned anything, so we can assume this as the perimenopausal stage, right? So what is perimenopausal stage? That means the menopausal transition period caused by fluctuating these ovarian hormones level. It starts several years before the menopause and end 12 months after the final menstrual period. In the woman with hysterectomy, this diagnosis is clinical, right? There's no hysterectomy. There's no uterus, right? Okay. So usual age is 40 to 50 years. Pathophysiology is fluctuating and the decline of the estrogen, irregular ovulation, yeah, irregular ovulation and variable progesterone level. So clinical features are like all like postmenopausal symptoms like vasomotors, hot flushes, night sweats, palpitations, irregular cycles, heavy or skipped periods, psychological mood swings, anxiety, poor sleep, irritability, vaginal dryness, dyspareunia, urinary symptoms, and the decreased libido as well. So this is a clinical diagnosis, and but we can check the FSH, but not routinely recommended. And menstrual history reliable after hysterectomy, right? In our case scenario, right? or patient is 4 years before there's a hysterectomy. There's no uterus. So how to manage? So first thing is we can do the lifestyle management, smoking cessation, exercise, sleep hygiene. Then we can think about the hormonal because these patients having some fluctuating hormonal levels. So in that case, estrogen plus or minus progesterone we can give depending on the uterus. If you are like remember that post-menopausal hormonal replace chart, you remember, right? Okay, we'll discuss about that as well. So in our case, patient after hysterectomy, right? In that case, estrogen alone is enough, right? We don't need progesterone to protect the uterus, right? Yeah, and non-hormonal. These are the non-hormonal one like SSRI, SNRI. If these menopausal hormonal therapy is contraindicated only. Otherwise, we always try to replace these fluctuating hormones. Okay, remember like that. So this is the chart I have mentioned. This is for the post-menopausal woman, but it's like almost same for the perimenopausal. Little bit there's a little bit changes because perimenopausal women have the still having the periods, right? And so it can be like a difference, and they need contraceptions as well, right? For the perimenopausal women. But in here, I have added to like explain you how you should remember this chart like by heart. This is prescribing MHT for women with no contraindications. So, what are the contraindications like previous history of DVT, right? Migraine, because they are contraindicated in estrogen therapy, right? You should know contraception is a very huge very huge lesson. Okay, but we will cover it before the February exam. So, before giving the menopausal hormonal therapy, we have to think about the uterus. If uterus intact or previous hysterectomy present. If the previous hysterectomy is present, estrogen only is enough. Here you all can see. If the uterus is present, then we have to think about the combination menopausal hormonal therapy. Right? Why? We need some endometrial protection, right? Because we are taking estrogen. So then, if the patient has uterus, then thinking about the combined menopausal hormonal therapy, we have to think about less than 12 months since last menstrual period or more than 12 months is LMP. So if the patient is less than 12 months, okay, if it is less than 12 months, that means like perimenopausal stage, right? In that case, transdermal continuous estrogen and cyclic progesterone. Here, cyclic progesterone we have to give. And oral continuous estrogen and cyclic progesterone. Here, just remember we have to give if the less than 12 months cyclic progesterone only. Right? Cyclic progesterone only if the patient's last menstrual period is less than 12 months. Okay, so cyclic progesterone plus estrogen continuously. It can be transdermal estrogen, oral estrogen, or yeah, the same thing they have mentioned. No, transdermal oral estrogen plus levonorgestrel IUD. Then, if the patient is having uterus and more than 12 months since last menopause, last menstrual period, in that case, we have to give estrogen and progesterone both continuously here. Transdermal continuous combined estrogen and progesterone. Oral continuous combined estrogen and progesterone. Transdermal low oral estrogen plus levonorgestrel IUD. Oral progesterone plus what is SCRA? Okay, I have to check it. But just remember like this, okay? If it is more than 12 months since LMP, it should be continuous estrogen and progesterone. If it is less than 12 months, more than continuous, less than 12 months, just continuous estrogen plus cyclic progesterone. Please remember that. But in our case, our patient doesn't have uterus due to the hysterectomy. So in that case, estrogen is enough, right? It's a very high yield, so you have to remember, right? If the hormonal therapy is contraindicated, in that case, we have to think about the amitriptyline. Okay. Okay. Thank you, doctor. It's selective estrogen receptor modulator. Okay. Yeah. So in that case, in our discussion, we can give estrogen, right? Okay. So all understand the question, right? Okay. So we will move to the next one. This is, please remember, this chart is very high yield. Usually, we can use this chart for perimenopausal and postmenopausal as well, like almost same. Okay. Please remember, about less than 12, more than 12, and the cyclic progesterone and continuous progesterone and estrogen. Okay, here continuous estrogen plus cyclic progesterone. Here both are continuous. Okay, let's move to the next question. Patient with continued GERD already on PPI. Next, what should do for management? Cis alcohol and smoking, endoscopy, PPI trial. So what do you think? This is a new thing. It's a new concept here. So what do you think about this question? Please type in the chat. Today we have like no like we have to cover this quickly. Okay. So why endoscopy? Who can tell me why endoscopy? Why endoscopy? Why? Just type your answers in the chat. You should answer. Mm-hmm. Okay. Yeah. Okay. So what do you know about the red flags in GERD? Okay, so you can read more from this guideline. This is also Australian prescriber. This is also like a free version of the therapeutic guideline, but it doesn't contain everything. Okay, just like we can give it a read when we can't find anything. It has like good thing. Okay. So in that case, what are the red flags in gastroesophageal refluxes? Recurrent vomiting, dysphagia, odonophagia, weight loss, evidence of GI bleeding, like hematemesis, iron deficiency or anemia, duration symptoms more than 5 years or less than 6 years, epigastric mass, age more than 50 years. So these are the red flags in GERD. Okay. Then there's one more small box in that guideline, Australian prescriber. It's an indication for gastroscopy in GERD. So, if patient present with these red flags, we have to anyway do the endoscopy. Or persistent symptoms despite an adequate trial of proton pump inhibitor in our scenario, right? Already on PP, but still continuous great GERD. So in that case, we have to do the endoscopy and find the cause, right? Here, the persistent symptoms despite an adequate trial of proton pump inhibitor. Then treatment of complications such as dilation of the esophageal strictures or evaluation of patients before and after anti-reflux surgical procedure. Screening for Barrett's esophagus in high-risk patient may be considered. So you can see in that case we can go with the endoscopy, right? You all agreed, so we will move to the next question, right? Got it right? Please type in the chat if you have any doubt. You can just ask. This is the guideline. It's a therapeutic guideline free version. Okay, here you can download this one if you want. Same thing they have mentioned. Yeah, yeah, these two. This one. Here's the approach management. That's why I have added it. Suggestive symptoms, any red flags. Okay, if any red flags, if it is no, PPI trial and empirical therapy for 4 to 8 weeks with lifestyle modification, adequate response, yes, it's full response change when required or step down the therapy. And if partial response, check compliance, check timing of administration, intensification of fatty acid suppression. Okay, like that. They have like a guideline. You can read it by yourself. Yeah. Today I'm just quickly doing it. Okay. Because we can't take like too much time for the November because we have October February doctors as well. They're requesting me to like quickly cover the October file as well, right? So yeah, you got it. These are the red flags you should remember. Please remember, okay? These two boxes. That's very important. The next one is man with rash on the back home. Antibiotic therapy with cefazolin for 2 to 3 days. Which one of the following should be advised? No cephalosporin, neither cephalosporin nor penicillin, no ciprofloxacin can give cephalosporin apart from cefazolin. So what do you think? So what do you think? Type your answers in the chat. Please hurry up, doctors. What do you think? What about other doctors? Mm-hmm. Okay. Okay, so let's little bit discuss about the theory behind it, okay? When we will come back. So mm, this is there's a beta lactam antibiotic allergy tool. This is in the therapeutic guideline. Okay, there's an antibiotic allergy tool. Okay, so from this tool we can check the hypersensitivity. Okay, this is the approach. I'll explain. Okay, before that we have to know about the type of hypersensitivity reaction. Is it immediate or delayed hypersensitivity? So what does mean immediate hypersensitivity? Immediate hypersensitivity mean IgE mediated hypersensitivity. That mean within 1 to 2 hours, right? Delayed hypersensitivity, the word delayed, that mean after days, that mean T cell mediated, right? Okay, so you have to remember the time of reaction. This is how we approach this patient. Then we have to identify the severity. In that case, okay, severe anaphylaxis, airway angioedema, hypotension, collapse, SJs, and rest and organ involvement. Okay, so these things can be seen. Non-severe one, just macular popular rash. So what is a severe one? It is IgE immediate, IgE, IgE immediated one, right? It's like anaphylaxis, right? The immediate one here. There can be anaphylaxis, airway angioedema, hypotension, collapsing in IgE mediated. That means immediate hypersensitivity. If it is a non-severe one, mean delayed hypersensitivity, there is a macular popular rash, mild urticaria, benign childhood rash. Okay. So then, what to prescribe? The next question is what to prescribe in these situations. And so, if the immediate severe reaction happen, yeah, after beta lactam, if the immediate severe reaction happen, we have to avoid penicillin and cephalosporin both, because immediate severe reaction mean the beta lactam IgE mediated severity, right? That means that can be anaphylaxis, angioedema, right? That's a life threatening. So we have to avoid penicillin and cephalosporin, and we can use non beta lactam antibiotic for these patients. Okay, so if the immediate non severe reactions happen, so non-severe one, immediate. As example, immediately like IgE mediated, but the symptoms are less severe. Like just a rash, okay, just a rash, but it's immediate, like within hours. Okay, in that case also we have to stop the penicillin. Like immediate cases, we have to stop penicillin, but in that case we can just give cephalosporin, because this is just an immediate non-severe reaction, just a urticaria, right? Here the non-severe one, just a maculopapular rash, mild urticaria. Like in that case we don't need to stop the other beta lactam, but the patient got this immediate non-severe reaction for penicillin, so in that case the avoidance of penicillin is enough, and cephalosporin are safer. Okay, and then talk about the delayed severe reaction. In that case, SGS, this is skin cutaneous drug rash, right? So in that case, avoid all penicillin and cephalosporin because this is severe. But if it is delayed non-severe, you have to just avoid penicillin only. No need to avoid cephalosporin. Okay, just remember like this. Then we will come back to our this chart. So in here, the same thing I have mentioned there. We have to check it is immediate or delayed. Actually, immediate within 1 to 2 hours, delayed within after days. Okay, like that here after days. Then severity. Severe mean anaphylaxis, airway compromise, hypertension, collapse, those are the severe one. The non-severe mean there's just urticaria or maculopapular rash, like that. In both the same thing. Okay. In the, here, the severe one, there's no anaphylaxis in delayed hypersensitivity. Severe one, it has the this SGS rash. Okay, usually, and non-severe one just usually maculopapular rash. So in that case, you can see, right? Immediate severe case, avoid penicillin. Here the avoid penicillin, like all the penicillin drugs, and in community-based patients, cephalosporin. Yeah, 1 minute. Yeah. Okay. Here the avoid penicillin and cephalosporin. Yeah. Then safe to administer. These are the avoid drug, penicillin and cephalosporin. Same thing. Safe to administer other non-beta lactam drugs, right? The same thing here, treatment with the antibiotic, non here non beta lactam antibiotic. Okay, okay. So in this case, here immediate non severe one, avoid penicillins only. Safe to administer cephalosporin. Here also the delayed severe case, avoid penicillin and cephalosporin, but safe to give non-beta lactam antibiotic. Delayed non-severe one, we have to avoid penicillin, and safe to give cephalosporin. So you know the concept right now. First we have to assess it, delayed or immediate one. Then we have to assess the severity. Then according to the severity, we have to think about we should avoid and what we can give. Okay. In this case, man with rash on the back home. Rash on the back home, antibiotic therapy, cefazolin for 2 to 3 days. Which one of the following should be advised? So, what do you think? He's with the cefazolin, so no cephalosporin, no neither cephalosporin, no penicillin, no ciprofloxacin can give cephalosporin apart cefazolin. So, what do you think? You get the concept, right? Yeah. Okay. Did you understand it? Did you? So, in our patient, in which category in here? Our patient just with the rash on the back home, so it can be non-severe one, right? Like, and the delayed one, 2 to 3 days after. So here you can conclude it as delayed and with the rash, and they haven't mentioned anything about like severe something. So it can be what? It can be what? Yeah, it can be delayed non-severe, right? So here, delayed non-severe, what we can do, I'm showing it again. I know some doctors have some confusion. Here, the delayed non-severe one, penicillin, we have, if we got the reaction to the penicillin, we have to avoid penicillin, amoxicillin, like all the penicillin. But safe to administer cephalosporin. Example like cephalexin, cephalotin, cefazolin, like that. Okay, and carbamazepine and astronom. So, what do you think in here? In a patient already with cefazolin, so this is what kind of drug? What about other doctors? What about other doctors? Only few doctors have answered. What do you think about other doctors? You should answer. Just tell me your opinion. Yes or no? What do you think? Just tell me your like answer. Or you don't understand or whatever. Do you understand? Mm. Yes. Okay. Okay. If this patient is present with okay in the cefazolin and 2 to 3 days after our patient developed the SJS rash, the severe one. In that case, what we can do in this category? Delayed severe. Here we had to stop all the penicillin and cephalosporin, right? Because they both have the beta lactam. So that's how we should think, right? Yeah. Okay. So let's move to the next question. If you have any problem or any doubt, please just ask. Okay. You have to follow this chart. Okay. Yeah. It's not hard. So, exclusion criteria for hypoglycemic episodes for driving. Exclusion criteria for hypoglycemic episodes for driving. Type your answers in the chat. What is your answers in the chat? Type your answers. Yeah, it's 6 week, right? We all know that. In 6 week, like after glycemic attack, we have to wait 6 weeks to drive, right? Yeah, usually after if there's a hypoglycemic attack and then after 6 weeks we have to wait, then we have to take the we have to uh we have to take the from road authority to drive our vehicles, right? We need to get certificate after this 6 week, to check if the patient is stable or not, like that. Okay, then for these patients, what we should advise before driving? For like usual hypoglycemic patients, what are the advices that we can give before the driving? Who can tell me? Who can tell me? Okay, let's check. Today you all feel like here you can remember these things, okay? And the same thing mentioning this in the chat. Yeah, doctor, these are the things here. Please remember these are high yield. Okay, if for this is not the answer for this question. I have added because in the November sometimes they can ask from that because they have already asked about the after a hypoglycemic attack, what we should like how long should we restrict the driving, and next time they can ask from this like what are the advices that we can give for the patient. So here we can address patient check the blood glucose level before driving and every 2 hours during rest break or longer car trips, and do not miss or delay eating snacks and meals. If you have if you have to drive long time, stop for regular snack break every 2 hours. So, know the signs of hypoglycemia. We should advise patients about the hypoglycemic features like feel fainted, like sweaty, light headaches, unable to concentrate, headache, pull over immediately. And we had to advise pull over immediately to the engine and check the blood glucose level with the meter. If it is less than 5 millimoles per liter, we have to follow the step 2. Okay, what is the step 2? Sorry, step 3. In that case, we have to take the fast acting carbohydrate, right? In that case, yeah. I yeah, the same thing. Yeah. And we have to tell the patient always take the hypoglycemic meter with them. Yeah, like that. Those are the main things we can advise patient. You can just give it a read while you are studying this again. Okay. Yeah. So the next question is the girl is obese, has diabetic mellitus and PCOS history. She started metformin and left it. Again started. What else to give? Semaglutide, clomiphene. What do you think? What do you think? Yeah, semaglutide, right? So, yeah. Okay, so what is PCOS? So, what is the diagnostic criteria for PCOS? Just tell me quickly. You should know this one. It's very high yield. PCOS diagnostic criteria. What are the other features? So we all know about what is PCOS. Huh? Okay. So diagnosis is made if an adult meet two of following diagnostic criteria. So what are these three diagnostic criteria? Menstrual disturbances including secondary oligomenorrhea or amenorrhea. First point. Second one, clinical or biochemical hypoandrogenism. And third one is polycystic appearance in ovary ultrasound. So, if we can fulfill two out of these three, we can diagnose it as the PCOS. Please remember these things, okay? Yeah, doctor. What is the physical appearance? No. What is the clinical appearance of hypoandrogenism? What is the clinical features of hypoandrogenism? Please tell me. Mm-hmm. Yes. Acne, hirsutism. Okay, yeah. These are the features. So they have mentioned clinical okay, biochemical hyperandrogenism. So additional features of PCOS, obesity, insulin resistance, subfertility. So patient is in obesity category, right? Yeah, okay. And now patient is having diabetic mellitus as well. Okay, so let's discuss how to approach the management of polycystic ovary syndrome. So here, in this case, symptoms and long-term health risk arising from abnormal follicular development and ovarian hormone synthesis can be seen in PCOS. While taking account of these individuals' goals for treatment, differ, okay, from the individual goals. Symptoms and health risk of PCOS are consequences of anovulatory menstrual cycle. Okay, so subfertility, irregular menstrual bleeding, lack of progesterone induced endometrial shedding. Okay, so these are the anovulatory problems. So consequence of excess ovarian androgen production, hirsutism, acne, androgenic alopecia. Then obesity, which affect the major of individuals with PCOS and increase the risk of complications, and insulin resistant exacerbation of hyperandrogenism, increased risk of type 2 diabetics, uh, and cardiovascular diseases. Okay, because we were discuss about the PCOS when we are doing the what CVS risk assessment, right? Okay, so here, most aspect of PCOS can be managed in general practice, but specialist referral is appropriate if diagnosis is uncertain. Hirsutism is not responding to the androgen therapy after 6 to 12 months, seeking infertility treatment. Okay, please remember these points. Then metformin for individual with polycystic ovary syndrome. So, patient also with this polycystic ovary syndrome and already taking metformin, but she's not continuously taking this drug, right? Do you remember the question? She's not continuously taking the drug. She has stopped, then again started. Okay, it's not adherence. Okay, I'll tell doctor. Yeah. In here, so after that, I will tell. Okay, after the treatment. And high risk for developing type 2 diabetics, okay, but our patient is already having diabetics. Then subfertility is an individual with irregular menstrual cycle, okay. Then BMI greater than 25 if sufficient weight is lost after 6 months trial of lifestyle changes. Metformin does not cause significant weight loss but may prevent the weight gain. You get the point, right? While taking this metformin, we can advise this patient to keep the healthy lifestyle, right? Because metformin is not the drug for obesity. It's just to, uh, but it can eventually help to control the obesity, right? Okay, that's what they have mentioned in here. So here, metformin also suppress the ovarian androgen production, which improve the frequency of ovulation in individual with PCOS. So metformin We can give 500 milligram orally with a daily evening meal and initial dose increase daily dose by 500 milligram every 1 2 weeks. And here, okay, so these are the things. But while taking this, our patient is already obese, right? In that case, we can advise our patient for lifestyle modifications, right? In that case, weight reduction is a one more thing, right? Okay, here. Yeah. Our patient is obese, has type 2 diabetes and PCOS. She already has been started on metformin but has poor adherence and restarted again. The next appropriate step is to address the weight reduction and glycemic control, which will also improve the PCOS features. So, first line PCOS with obesity and insulin resistance, lifestyle modification plus metformin. So, we already tried. Our patient is not adherent. Then, if obesity and diabetes persist despite of alongside metformin, we can add GLP-1 receptor agonist, right? Such as semaglutide for significant weight loss, improved insulin sensitivity, better glycemic control. Secondary improvement in menstrual irregularity and hyperandrogenism. So the same thing they have mentioned. So in that case, what do you think about this question? So we can go with semaglutide to reduce the obesity of this patient, right? You agreed with the answer, right? That's how we got this semaglutide. Okay? You understand it, right? Or do you have any other doubts? Let's type in the chat. Okay, you understand. One doctor has asked about the um these like how LH and FSH present. So in LH and FSH ratio is increased more than 2.2 to 1. Okay, the ratios increase more than 2 to 1. Usually LH2 and FSH1. So more than that, this is increase. Okay, remember that thing. Yeah. Okay. So you know how we got this point. And we have so many other treatment, right? For PCOS, this is for obesity and the glycemic control. So then when okay, 1 minute. If the patient is presenting with irregular menstrual cycles or oligomenorrhea or amenorrhea, then what we can do? In that case, what we should think about? In that case, we can think about combined oral contraceptives, right? Yeah, these are the provide most effective menstrual regulation in PCOS. This is a like multidisciplinary approach, right? In that case, for the um, menstrual problem, we can give combined oral contraceptive or levonorgestrel releasing IUD. Please remember these things, okay? Yeah, that thing I have mentioned, weight control in polycystic ovary syndrome. Yeah, the same thing. I have added everything from polycystic ovary syndrome. You have the TG in here also. You can just highlight it, okay? Yeah. So the next question is a 40-year-old woman present with a weight gain hirtu- uh, hirsutism, and irregular menstrual cycle. Pelvic ultrasound show the polycystic ovaries. She does not wish to conceive currently. What is the most appropriate first line management? Lifestyle, metformin, combined oral contraceptive, clomiphene, citrate. What do you think? What about other doctors? What about other doctors? What about other doctors? So in that case, in they have mentioned, so yeah, first thing we have to think about lifestyle modification like weight reduction, right? So those kind of thing. In here also they have asking about first line treatment. Then we can think about lifestyle modification. But if you ask like what is the best next step like that, the best one to prevent these PCOS to these like features and everything, then we can go with the COCP. Otherwise, the first line is lifestyle modification, right? Yeah. Yeah. Okay, you are correct. And we have something here as well. She does not wish to conceive currently. Okay, in that case, we can think about like they are giving some hint for the COCP as well, right? Okay, yeah. Okay, so let's move to the next question. It's a distraction to go with the COCP. Okay, it's fine. So the next question is pregnant woman present with pelvic pain and disorganized with diagnosed with pubic symphysis dysfunction. What is the most appropriate next step in management? Physiotherapy, analgesia, pelvic support belt, or orthopedic referral. So what do you think? What do you think? Okay. We got two answers. Okay, let's discuss a little bit about what is pelvic girdle pain in pregnancy. So, what is pelvic girdle pain in pregnancy? It is arising from the pelvic joint during the pregnancy, felt between the posterior iliac crest and the gluteal fold, often near the sacroiliac joint. Pain may be involved the pubic symphysis. It can occur along with lumbar pain and lead to reduce the ability to stand, walk, or sit. So here, causes can be enlarged in uterus if the shift center of the gravity, right? This can increase the lumbar lordosis and pelvic stress, muscular reduce lumbar pelvic muscle strength and coordination, joint factor, increase pelvic joint mobility and instability, and hormonal relaxin role unclear, no consistent correction with severity. Okay, so just remember these main things. Central uterus can cause the um, gravity, center of the gravity, and make a stress in the pelvic rim like that. So risk factors: previous pelvic or lower back pain, prior pelvic or spinal trauma, multiparity, high BMI, so smoking. These are the risk factors. Clinical features: mechanical pain, worse with activity. This is the chat. Mm-hmm. Mechanical pain works with the activity, improve with the rest, and pain with walking, standing, climbing stairs, turning in the bed, and reduce functional capacity. Just functional, okay? Pain reproducible on specific provoke and test. I'll show it. And you have to remember in red flags as well. Okay, there's a good RSCGP guideline. I got everything from there. Okay. Yeah. This is the red flags of this pelvic pain. Okay, so red flags are pain in the absence of mechanical stimuli. Okay, and the unexplained weight loss, suspicion of some cancer, neurological symptoms like saddle anesthesia, acute onset radicular pain. Okay, so these are the like red flags you should remember. Okay, anyway, you know if there is a suspicious of the um, saddle anesthesia, we can think about what saddle anesthesia, where we can see saddle anesthesia. Yeah, it's called equine, right? So please remember these things. Okay, very high yield. Yeah. Okay. So and incontinence, so bladder and bowel dysfunction, significant trauma history like fall from height, heavy lifting, vaginal bleeding, fluid loss, and pyrexia of unknown origin, fever of unknown origin. These are the red flags. Okay. So examination. This is a clinical diagnosis, and yes, that picture. Yeah, these are the provokant test. Okay. Let's see. These you can give it a rate later. These are the provokant test. Okay, and you can give it a rate. You're not asking from that. So investigation, no need, right? Unless there's a red flag. Yeah, consider only if the red flags are or atypical features present. So management, first line is reassurance and education, activity modification like avoid single leg weight bearing, sit to dress, avoid wide hip abduction, reduce prolonged standing or stair climbing, low heel shoes, heat packs for painful labor. These are the like advices we can give for this patient. And physiotherapy. Physiotherapy is the core stability and pelvic strengthening exercise. Gluteal and adductor muscle strengthening postural advice. Okay, so physiotherapy, we treat the cause, right? Usually, this is like a big uh, in involvement to this pelvic pain. And the supportive treatment, pelvic support belt. It is for short period to correct lifting. This can give the like a short term relief. That's only that, not like help to reduce the like mechanism and this functional problem. It doesn't help to reduce the this problem like the cause and everything, but it can give like sudden relief, right? Just only for this belt. What about analgesia, paracetamol we can give for the pain. Okay, yeah. Yeah, for the acute exacerbation, need short-term bed rest. Consider thromboprophylaxis if prolonged immobility. We know if the patient is bedridden, we have to think about the DVD prophylaxis, right? That's another thing. And when we should refer if there's a red flag, neurological deficit, severe or not response to the conversive management, suspect a serious condition like this. Okay, so let's go back to our question. In our question, woman present with the pain and is diagnosed with the pubic symphysis. What is the most appropriate next step? So in that case, they ask it most appropriate. In that case, we can go with the physiotherapy, right? If they ask what we can do to like get a like immediate relief to short term pain relief, so in that case we can think about pelvic support belt and analgesia, right? Otherwise, like physiotherapy is like a first line treatment. We are like strengthening the muscle, right? So in that case, yeah, here the physiotherapy is most appropriate because it treats the underlying biomechanical instability, provide pelvic stabilization exercises, teach the posture, movement, and activity modification, has the strongest evidence for functional impairment. What about the pelvic support bell? I know the confusion between these two, right? Even like before discussing this part, I saw while you're answering. So, pelvic support bell provide temporary symptom relief only. Temporary symptom relief. Do not correct muscle imbalance or joint stability. Are recommended in additional to physiotherapy, not instead of it. So you got the question and you uh, agreeing with it, right? The answer, or do you have still confusion about this belt? Yeah, you got it right. So we know like they are asking most appropriate one, right? In that case, we have to cause the underlying we have to treat the underlying cause, right? In that case, physiotherapy is better, right? Okay. Please read these things, highlight, okay? You can do whatever you want in the file. And please like make sure to don't share outside the group, okay? If I like find out someone is shared outside, like I can't give the downloadable files in the future, right? Because I'm like taking so effort and so much time wasting, and still like if other doctors are sharing, it's not respectful, right? So yeah, because no one is giving these files as a downloadable version, right? Yeah, but I believe you, don't worry. Okay. Okay, so next one. Doctor, can we take like a 10 minutes break? I really need a coffee today. Okay. So we'll take 10-minute breaks and we'll continue long, okay? Because we have to continue so much. No, doctor, we will now take 10 minutes break. Then later we will think because I want to finish this file. This file also have day 5 questions as well. Okay, so we should finish it. Then we will do day 6 questions in next day. Okay. Yeah. Thank you so much. We will. Okay, now the time is 7:24. I'll come back 7:34. Okay, thank you. Hello, doctors. Hope you all back. Okay, so let's discuss. Am I too speed today? Or is it okay? Because I'm like explaining bit not slowly today. Yeah, okay, because in previous days I'm like explaining very slowly because but we didn't have time. Okay, so because we have to finish today's file, okay? So, 4-year old girl 10 days ago had a runny nose and loose stool for 2 days but recovered. Started to having abdominal pain 5 days ago. Feels teary before going to the toilet. Examination shows the tenderness of lower abdomen, which is most possible to investigate first. midstream urine, clean midstream urine, clean catch urine. Okay, check for celiac, X-ray, abdominal ultrasound, CT. So, what do you think? I know this question is kind of controversial. STEM is not like completed as well. So, what do you think? Like, what about other doctors? Mm. Okay, what about other doctors? Mm-hmm. So, what do you think about the diagnosis of this case? What do you think about like what are the possible possible diagnosis in this case? Possible ones? Mm-hmm. What do you think? UTI. What about other doctors? Why UTI? Why UTI? Like why you are thinking it's as a UTI? She's having a runny nose, previous upper respiratory tract infection, right? 2 days ago recovered. Low abdominal pain. And what about like feel teary before going to the toilet? I think they mean what? And what about the examination show the low abdomen tenderness, which is possible investigation first? I know this question is controversial. You are thinking about the burning sensation. Okay, burning sensation, painful urination, urinate. Or you take this as the urinating, what? Yeah. And other time we can get it as a feel teary before going to toilet as like something with the defecation, right? Think like that as well. I know this question is controversial, right? In this case, we can think about UTI as well. But what about the mesenteric adenitis? What do you think about it? Mesenteric adenitis. So what do you think about it? Mm-hmm. Yeah. So we can think like that also. And previous history of respiratory tract illness, right? And now presenting with abdominal pain, and child can become teary when try to open the bowels, right? And lower abdominal tenderness. But patient doesn't have any symptoms like vomiting, like biliary vomiting, or like red jelly stool. So we can exclude intussusception, right? Because otherwise we can think about intussusception as well, right? Yeah. So like yeah. So what do you think? What about adenitis? Yeah, that's the problem, doctor. It's like controversial question. Like as other doctors mentioned, they can think about this as a UTI as well. But sometimes we can like, but I feel like more related with like mesenteric adenitis, right? Due to the recent upper respiratory tract infection, this tearful during opening the bowels, abdominal pain, and there's like tenderness, abdominal tenderness, right?
Yeah,
So
adenitis could be, but in case of adenitis, will there be a constant pain or just before going to the
colicky
toilet?
abdominal pain in the mesenteric adenitis.
Yeah, and would it be continuous or intermittent?
It's like,
If it's inflammation of the colon, then it should be continuous pain, right?
yeah, but it's depend, right?
It
Even
could be intercession too, but it's not UTI, that's for sure.
yeah. And that's the problem. Even we have to like exclude the intersusception because there's no vomiting, usually vomiting and the what other things like red jelly current, stool and everything like feel like adenitis, but the stem is not enough, right? Because they have given like a loose stool for 2 days but recovered due to the previous gastroenteritis, right? Upper respiratory tract infection or after a gastroenteritis. So patient can have the mesenteric lymphadenitis, usually colicky abdominal pain, right? Mm, That's why I'm telling this. This is a controversial question. We can't like get a proper explanation from here. So we should know how these things present, right? And here, like mesenteric adenitis also, it's like episodic pain, right? Episodic colicky abdominal pain. But I think it's better to do abdominal ultrasound because for the adenitis, so interception or whatever, like we have to do the ultrasound, right? Then, as example, in adenitis, what we can see in the ultrasound, we can see enlarged mesenteric lymph nodes, right? Yeah, we have to think like that because we can't take any answers for this question. Yeah, age group is unlikely for the interception, right? Yeah. Yeah, so in this case, yeah, it's an incomplete question. We can't take an answer, right? But just remember how mesenteric adenitis is present, how UTI present, right? That's the only thing you can hear. There's no obstruction. This doesn't feel like this is obstruction. I'll add about the how mesenteric adenitis is present and UTI also present, then you can easily differentiate, right? Yeah, but sometimes it can have doctor due to the like because this is a adenitis mean the lymph nodes problem, right? Inflammation, right? Inflammation, sorry, inflammation. Due to the inflammation, we can think about that as well. Mm, That's the problem. We can't waste our time here, right? I'll add about the mesenteric adenitis and how the UTI present. Do you have any other differential diagnosis for this question? Because we are missing something in this question, right? Anyway, we can think about the abdominal ultrasound because like we can identify what's inside the tummy, like we can identify as a different things as different, like as example if it is If you're suspecting interception, we can see the donut lesion like that. If we are suspecting mesenteric adenitis, we can see enlarged, uh, enlarged lymph nodes, right? Yeah, like that. So it's fine, doctor. Don't think too much because we got like good amount of recalls, and sometimes we can find these questions, you especially specifically in the last days. Okay, due to the questions are getting harder, right? Even yesterday also we got some question about that malingering and temporal lobe epilepsy. That's also a controversial question, but still we have to we have to take those questions, right? So the best thing is we should know how this UTI present, and how mesenteric adenoid is present, like that. Do you have any other differential diagnosis for this scenario? Okay, if no, we can move. I'll add some explanation for here, but I'm not choosing anything for this question. Yeah, constipation also it could be because usually in the they are giving questions, they are mentioning about the constipation feel teary before going to toilet. This part also mentioned in the functional constipation, right? Yeah, yeah, different DD, but we should know each and everything, right? To differentiate. I'll try to find the eMedici question, but I'm not sure. I tried to find, but I couldn't find anything. It's fine. We will move to next question. Okay. Because we can't wait so much time for like one question. Okay. A young child present with diarrhea and abdominal pain. Diarrhea has resolved. Same question. Abdominal pain persists. The child is teary before going to the toilet. Examination shows the tenderness in left lower quadrant without guidance. What is the most appropriate investigation? In here, we only got abdominal ultrasound and CT scan, right? The same question. Okay, we'll move to the next one. A woman reports shortness of breath while eating dinner. She has tachycardia and tachypnea. ECG shows the sinus tachycardia. What is the most likely to diagnosis? Type your answers in the chat. Is it MI or pulmonary embolism or pneumothorax? Mm-hmm. What about other doctors? Mm-hmm. Okay. Mm-hmm. Yeah, yeah, correct, doctors. Here we can think about pulmonary embolism, right? Yeah, you're correct. Here, why? Yeah, and the most common ECG sign of pulmonary embolism is what? Sinus tachycardia, right? Do you remember? If you have forget everything about pulmonary embolism, please go and watch that video. Okay, I have explained like one one by one. Okay, yeah, that's the most commonest one in sinus tachycardia because in eMedicine they have asked in one question they have given the pulmonary embolism scenario and asked what is the most commonest ECG feature in the pulmonary embolism. It is sinus tachycardia. Okay, because there's a something else I'll show. I still didn't get time to upload all. Sorry. Can you see my screen? Okay, I think something happened. Sure. I still didn't get time to upload all the videos to YouTube. And I really want to upload everything, but have no time. I'm actually stuck with the what? These record classes. Yes, my pulmonary embolism. Here, I'll show it to revise. Yeah, here you should know. Well, you should know risk factors. Okay, and you should know the diagnosis strategy. I'm not taking too much time for this, okay, because I have already discussed this part and you should know Bell's criteria. And in our question, they haven't asked about diagnosis or anything, just ask us to diagnose the disease, okay? We have discussed this. Please watch the video. I have discussed one by one, okay? The treatment. That's the ECG. Yeah, sinus tachycardia is the most commonest one. And they have like specific one S1, Q3, T3 because most of the doctors are thinking if they ask most common sign of the ECG, they think about this one because this is specific, but this is specific. But the thing is, this is very rare. Okay, so commonest one is sinus tachycardia, right? It is in this doctor. Oh yeah, this part. I'll add this from the therapeutic, sorry, RCH, right? This is for commonest, right? This is like overall common explanation for abdominal pain, right? I saw this. Yeah, thank you so much, Dr. Vagya. I'll add this, yeah. Okay, so please remember these things. I'll show that question answer, then you won't forget it. That's it. So I have a question. So when a patient present, a pregnant patient present with the chest pain and shortness of breath, and already exclude the lung pathology by doing chest X-ray, and then they are asking what is most appropriate next step is CTPA or VQ scan. What do you think? Type your answers in the chat. Yeah, it's a VQ scan. Please don't forget it, okay? If VQ scan is not in the option, then we can think about CTP. Otherwise, always VQ, VQ, VQ for pregnant, okay? But first thing, we have to rule out the lung pathologies by doing the chest X-ray because it's shortness of breath, right? And chest pain. So in that case, we have to rule out. So how myocardial infarction present? So what is a typical picture of the MI? Who can tell me? How typical MI present?
Chest pain drifting to the left side,
Mm-hmm.
left shoulder, jaw, and arm.
Yeah, it's a stabbing, a very severe chest pain, right? It's like
Mm.
pressing,
It's like
pressing your
something
heart.
pressing in the chest.
Yeah, pressing the chest like chest pain radiate to the left jaw, left hand, right? Sometimes it can present with the atypical presentation with as a epigastric pain, right? Sometimes we misdiagnose this MI as a gastritis, right? This is the typical presentation of, yeah, typical presentation of the MI. So how pneumothorax present? Pneumothorax has like different types, like we already discussed about the primary spontaneous pneumothorax and the tension pneumothorax, the treatment algorithm, everything. Okay, usually tension one with the some accident, right? With the severe chest pain, SOB, shortness of breath, right? In the spontaneous one, sometimes it can be just like a shortness of breath only. We discussed yesterday as well, like related with the Marfan syndrome. Yeah, yeah, doctor. So you should know the how it's present. Yeah, here the same thing I have mentioned. Yeah. The next one is a young girl started on antipsychotic medication, present with back pain and paraspinal muscle spasm, causing abnormal posturing. On examination, paraspinal spasm and tenderness are present. What is the most appropriate management? Benztropine and midazolam. What do you think? Yeah, it's benztropine. So what is acute dystonia? So how acute dystonia present? So what are the other extrapyramidal side effects from the antipsychotic drugs? These are very high extrapyramidal side effects of the antipsychotic drugs, right? We already discussed that huge chart. Do you remember? With the metabolic side effect, extrapyramidal side effects, and what are the other things? There are so much side effects, right? And the immediate sedation. Do you remember that question? They are asking what is immediate adverse effects. Do you remember that question after risperidone? So now they are asking about acute dystonia. So what are the other extrapyramidal side effects? You remember what are the other extrapyramidal side effects? Who can tell me? You should know. There are different types of extrapyramidal side effects. So what are they? Type in the chat. Mm-hmm. Yeah, acute dystonia, tardive dyskinesia. Then what? Mainly main tree, Parkinsonism, akathisia, right? You should remember these things like a pro, okay? Acute dystonia, Parkinsonism, and akathisia. And tardive dyskinesia. These four are like very high. Okay, today we got only acute dystonia. Let's discuss about acute dystonia. So, for advice here, how acute dystonia present? It's a brief muscle contractions resulting in twisting movements or abnormal postures. Dystonia often affect the face, neck, trunk, but can be focal, multifocal, segmental. Segmental mean affecting more than one contiguous region or generalized. Here, this is a very specific one. Oculogrytic crisis. How this oculogrytic crisis present? I'll show a picture. Please remember that one, okay? How it present. Yeah, please remember, okay? How this um, oculogyric crisis present. Yeah, yeah. Please remember, okay? Yeah. Okay, let's move back to our this thing. Oculogyric crisis. Laryngeal spasm and opisthotonus can be seen. What is opisthotonus? Do you know what is opisthotonus? Yeah, I'll show a picture. Here, this is the opisthotonus. It can be from the tetanus as well, right? Yeah, there's a muscle spasticity in here. Like we're a very rigid muscle. Okay, please remember these things, okay? Here, the actual patient with opisthotonus. You have to remember this is a one sign from tetanus as well. Okay, so minute. Okay, so please remember uh, from these pictures. Yeah, so antipsychotic induced dystonia occurs most often in young male. So how we should treat these patients? Please tell me the algorithm, not the definitive treatment. Just tell me the algorithm. It's very high yield, okay? Usually they are not asking directly what is a drug of choice. We have to follow the algorithm. How? Who can tell me? Okay, first thing first. First thing, we have to stopping or reducing the dose of other dopaminic antagonist. So, as example, if the patient is on two drugs, as example, patient is taking metoclopramide and risperidone. So, in that case, either we have to stop this drug or we have to reduce the dose of this drug. The next thing is if only our patient is taking other dopaminergic antagonist only, okay? Otherwise, the first step is reducing the antipsychotic dose. Here, the reducing the antipsychotic dose. Next one, if it is not working, we have to switch to an antipsychotic less likely to cause this extrapyramidal side effect. Okay, if everything is not working, the last option is the benzotropine. Okay, benzotropine for these symptomatic as a symptomatic treatment. So how? First, we have to reduce the antipsychotic dose. Or if the patient is already on, as example, remember like this, risperidone and metoclopramide. In that case, they have to stop or reduce the metoclopramide as well. Then reducing is not effective, then we can change to another drug like with less side effect. In that one also not effective and patient still having symptoms. In that case, we have to think about our last option as benzotropine. Please remember, okay, benzotropine as the last option, but you should know the algorithm how we treat. So what about what is a drug of choice for akathisia? It's not in here. What is a drug of choice for akathisia? Say extra after with antipsychotic side effect. As an antipsychotic side effect. Akathisia drug. Yeah, propranolol, right? For acute dystonia and Parkinsonism, these two adverse effects, we can give benzotropine. But for akathisia, we have to give propranolol. First one. The second line is clonazepam or diazepam. Like that. Okay. So what happened in akathisia? What does mean akathisia? Akathisia mean urge to move, right? Yeah, it's the patient has an abnormal urge to abnormal sensation to move. Yeah, okay, yeah. So, but today's topic is acute dystonia and we have discussed it. I'll explain everything in the psychiatric topics, okay? So don't worry. Yeah. Our next question is in frontotemporal dementia, which feature helps to confirm the diagnosis, confabulation, or disorientation? So, what do you think? They're asking to confirm the diagnosis. What do you think? What do you think, doctors? What do you think? To confirm the diagnosis. Okay, it will be discussed about frontotemporal dementia. So, how these frontotemporal dementia are present? What are the symptoms? What are the symptoms? So, we have behavioral changes, and we have personality changes. We have executive dysfunctions like poor planning, impaired judgment, speech and language problems, reduced speech, word finding difficulty. That's in the chat. Yeah. Then we can see the confabulation and poor insight due to the frontal lobe involvement. So, what is mean confabulation? What's the meaning of confabulation? Confabulation means the production of false or distorted memories without the intention to lie. That means there's a pa- these patients have the different memories, but they are not real. They have memory gaps, right? But they think that's real. Okay, here, the person believe the information is true occurs due to memory gaps being unconsciously filled and commonly with frontal lobe dysfunction. So in that case, this feel like severe one, right? So in that case, we can go with confabulation, right? Even disorientation is an example, but usually even in delirium cases also, we can see the disorientation, right? Specifically behavioral and cognitive dysfunction when it's affected frontotemporal dementia. Okay, let's move to the next question. Yeah, okay, there's a question. 50-year-old man present to the GP with his spouse who is concerned about change his behavior over past year. He has become increasingly sorry, apathetic and withdrawn from family activities. His spouse reported that he repeatedly walks the same routine around their neighborhood for hours each day, makes sexual inappropriate comments to strangers, and has developed an obsession with eating only sweet foods, gaining 10 kilo weight. He was recently dismissed from work due to inappropriate behavior towards the colleagues. He has previously been treated for depression with sertraline for 6 months without improvement. He has no other medical history and currently not taking any medication. On examination, he appears indifferent to the consultation but is cooperative. His vital signs are within normal limits. He is score 29 from 30 MMS examination, losing 1 point on attention. He scored 26 from 30 on Montreal Cognitive Assessment with deficient in verbal fluency and abstraction. Clock drop in his normal neurological examination reveals slightly reduced facial expression but otherwise unremarkable. Blood test and everything is normal. MRI shows the mild frontal lobe atrophy. Which one of the following mostly diagnosis? Yeah, it's a frontotemporal dementia, right? This is a good case scenario, so just you can give it a read and think about it. Okay, so in this case, they have mentioned like so much things about frontotemporal dementia, so you can read it here. The answer: frontotemporal dementia can present with prominent psychiatric symptoms that mimic primary psychiatric disorders. The presence of stereotype behavior and eating changes are the key discriminating features of behavioral variant frontotemporal dementia. Normal performance on bedside cognitive testing does not exclude the frontotemporal dementia if behavioral features are present. Okay, please remember how these patients are present. Okay, so there's one question. 25-year-old intellectually challenged woman come with her mother. Her mother, who is the primary carer, requests sterilization of her daughter. The daughter has painless menstrual bleeding but become agitated during that time. The mother has to care for her along with three other children. What should be done? Sterilizer refuse as this cannot be done at this age. Tube sterilization refer for governing body approval hysterectomy. What do you think? Type your answers in the comment section. Sorry, doctor. Yeah, sorry. So sorry. Yeah. In here, I was explaining. Okay, so sorry for that. In this case, first we have to assess the capacity, right? Because in this, even though it's her intellectual challenge woman, we have to assess the capacity. Why we should assess the capacity? We should know if the patient is understand what is sterilization mean. The assess capacity mean that understand the risks, benefits, and alternatives. Communicated decision. These things, but our patient is intellectually challenged, but still we have to assess the capacity. Then we have to think about this in this question. The mother is the one who need her daughter's sterilization, right? Not the daughter, right? Because she's kind of agitated during that time, but she's having normal menstrual bleeding, right? She's having normal menstrual bleeding. There's no indication for sterilization. Okay, there's no indication, like there's no therapeutic indication for sterilization in this case. But the only thing is, mother is asking for that. In that case, the patient is painless, normal menstruation. Here, no medical indications such as malignancy, uncontrolled bleeding, or life-threatening disease. Okay, so the request is due to this agitation. Okay, from the mother. In here, non-therapeutic sterilization of a person who lack capacity is classified as a special medical procedure. It cannot be done on parental or carer request by a doctor alone. Even if the care burden is high, it must get the approval from the legal authority such as guardianship tribunal or court. So in that case, we have to go with this governing body approval, right? You all get the point, right? Yeah. Okay, because this is a non-therapeutic indication. There's no threat to her life due to this menstruation. This it's everything is normal, just only her mom's request. Okay, in that case, we have to get the governing approval. Okay, so we'll move to the next question. So, if you have any doubt or question, just ask, okay? A child present with cough, fever, diarrhea, and abdominal pain On examination, there are no clear abdominal sign. Chest X-ray show the pleural effusion. What investigation would confirm most likely to diagnosis? Pneumococcal PCR, pleural fluid aspiration. So, what do you think in this case? What do you think? What do you think, doctor? Type your answers in the chat. So, okay. What is your answers? What do you think? Just type something. Mm-hmm. Okay, so here this is like a para pneumonic effusion, right? Patient with cough, fever, and in the children, uh, children can see diarrhea with pneumonia as well, right? As an atypical thing. In here, cough, fever, and abdominal pain. So in that case, we can think about parapneumonic effusion, right? As a complication of pneumonia that lead to the pleural effusion. So in that case, to confirm the diagnosis, we can do the pleural fluid aspiration, right? We can do pneumococcal PCR as well, but thing is to confirm, we can get the samples from this pleural fluid, then we can take the histological and pathologies like if it is exudate, transudate, and what is a sensitive organism. Like we can confirm everything from that, right? So I think better is pleural fluid aspiration. You all agreed, right? Should we move to the next question? Yeah, this is the same thing I have added from the. We have discussed this from. Oh no, we haven't discussed it. Okay, here. Usually, pleural effusion is a pathological collection fluid between the parietal and visceral pleura. We all know parapneumonic effusion is a pleural effusion associated with the adjacent pneumonia. Simple parapneumonic effusion is non-loculated transudate, which is sterile. And the complicated parapneumonic effusion is loculated effusion or empyema with changes in the pleural fluid due to bacterial invasion of the pleural space. Okay, so in that case, patient can have fever, tachypnea, cough. In our case, also fever, cough can see, and increased work of breathing, shortness of breath. That means pleuritic chest pain or abdominal pain. Examination: the patient is lethargic, hypoxemic, tachypnea, chest rolling, drawing, splinting, retraction due to this effusion. It's very hard to take breath if it is complicated one, right? For children, we have to assess the severity. We know what is that table for pediatric respiratory severity. Do you remember that pneumonia table when I have showed during the pneumonia lesson? If you don't remember, please go and check that one. Okay. Yeah. So here investigation. No laboratory tests are diagnostic, but consider the following: FBE, UEC1, CRP, blood culture, LFT, specific test, viral swab including COVID-19 influenza, pneumococcal PCR, testing for Mycobacterium tuberculosis, consult with local infectious disease team. If insert in a drain, consider sending the pleural fluid for gram stain, pneumococcal PCR. So, and chest imaging, anterior posterior chest X-ray, chest ultrasound, chest CT. It's not routinely recommended. So, what do you think about this one? Here they have mentioned specific test. pneumococcal PCR, or we can take the this one test in the, we can insert the we can do the drainage and consider sending pleural fluid for the gram stain and pneumococcal PCR. I think we don't know if it is bacterial or viral. In that case, better to go with the pleural aspiration to take the pleural fluid. Then we can do the gram staining for the bacterial one, or if we can do the PCR for pneumococcal, right? Like that. You'll get it right. We can do. Why is not blood name? Here they have mentioned the blood as well. But we, in our case also, we don't know, like better to grow here. We can do the pleural fluid and blood as well. They have mentioned here. Here, pneumococcal PCR, blood, pneumococcal PCR for pleural fluid as well. So in that case, I think better to go with drainage, right? If it is like a complicated one, so we can do the drainage and test for the gram stain and PCR, like to confirm the diagnosis, right? Because there's a fusion, right? We need to check whether there is what's inside here in this fluid aspiration. And otherwise, we have to do the pneumococcal PCR. But from these two, I think better to go with pleural fluid aspiration, right? Yeah, less invasive, but they ask investigation would confirm most likely diagnosis. Yes, only for the pneumococcal, right? This is specifically for the pneumococcal one. So what about other pathogens? We don't know, right? So in that case, we can to confirm exact diagnosis. In that case, we can go with fluid aspiration. What do you think? Are you agreeing? No. What do you think? What's your opinion? Just type. Yeah, because it's only for pneumococcal PCR, right? But we have, if we have pleural fluid, we can like test and send for the pathogens and do the gram stain. We can do everything, right? To get a proper confirm the diagnosis, right? That's the point, to confirm most likely to diagnose. So in that case, pleural fluid aspiration we can go. Yeah. Okay, so let's move to next question. Okay, the same thing. You can read it later. I did everything. Our time is almost gone, right? It's 8:23. I don't know how fast this time is like flying, right? But I like to do the this recall things than theory part. It's kind of like interesting, right? We have to think, we have to argue, we have to check others' opinion. It's like kind of funny though, right? What do you think? Do you like theory class or recall class more? What do you think? Do you like my theory class or recall class? Like, what is the like your favorite thing from these two? Hard to decide. Okay, thank you, doctor. No, I'm just asking, like, from these two, we have to select one, okay? In the MC, you can't select both answers. So now you also have to select one. Okay, okay, I was just kidding. Okay, just asking. Because I love to do recalls than theory. It's like, thank you so much, doctors. Theory feels like kind of boring, like same topic. Yeah, and the reading from like top to bottom, but this is like interesting, right? We have like not fully completed question, incomplete question. We have to like think so much, think so hard in this case. Okay, so next question is a patient present with ongoing psychological symptoms for 2 years. Uh, 2 years after car accident. She reports recurrent nightmares related to the accident and avoid going out because it reminds of her event. Which one of the following additional feature would help to confirm the diagnosis? Hypervigilance, avoidance of reminders, traveling by bus, flashbacks. What do you think? Mm-hmm. Okay, flash. So, what is hypervigilance? What is hypervigilance? What does mean hypervigilance? Mm-hmm. Yeah, he's always so conscious about like environment because due to this trauma, right? He always think this can happen, and he always alert, right? Yeah, yeah. Okay, so let's little bit discuss about this PT is right post traumatic stress disorder PTSD. So what's the DSM-5 criteria for this post traumatic stress disorder? So here the person was exposed to actual or threatened death, serious injury, or sexual violence as follows: directly exposed, witnessed in person, indirectly or repeated or extreme indirect exposure. These are the exposure thing. Then nine or more symptoms from any of following five categories with onset or exacerbation after the traumatic event. To diagnose these post-traumatic disease, we have to the patient has to have nine or more than symptoms from these following. Okay, so we have 14 symptoms. Okay, let's check. So there are different categories. You don't have to remember this everything. Okay, I added this to explain. Okay, explain. So symptoms of intrusion: negative mood, dissociative symptoms, avoidance symptoms, and arousal symptom. So what are the intrusion symptoms? Recurrent involuntary and intrusive distress in recollections of the event. And recurrent traumatic nightmares, dissociative reactions like flashbacks, which may occur on continuum from brief episodes of complete loss of consciousness, intense or prolonged distress or physiological reactivity after exposure to traumatic reminder. So in here, like just reminder in it, like just getting flashback, just getting nightmares. So just remembering it, okay, unconsciously. So the negative mood, persistent inability to experience the positive emotions, like inability to experience happiness, satisfaction, or loud feeling. Then dissociative symptoms. So what are the dissociative symptoms? That mean an alert sense of the reality of one's surrounding or oneself, like seeing oneself from another perspective, being in a day's time slowing, inability to remember important aspects of the traumatic event, especially not due to like head injury, alcohol. So we have to exclude this anyway. Okay, so avoidance symptoms: effortful avoidance of distressing trauma related thoughts or feeling, effortful avoidance of trauma related external reminders like people, places, conversations, activities, situations like that. Arousal symptoms in here sleep disturbances, irritable or aggressive behavior, hypervigilance, hypervigilance, and problems with concentration, exaggerated startled response. So these are the symptoms of post-traumatic stress disorder. Okay. So what do you think about from like hypervigilance and the flashback? What do you think about what we should go with? What do you think of from these two? Mm-hmm. Okay. Hypervigilance flashback. Okay. In this case, this also bit like weird question because like to confirm the diagnosis. Okay. To confirm diagnosis, we need to have like more stems. Sometimes they can give those symptoms like more symptoms here. So in here, the recurrent nightmares and flashbacks are all in one category, right? One category. And like hypervigilance in another category. So we are here. Arousal symptoms, the hypervigilance in this category. And these nightmares and everything is this in intrusion category. So what do you think? Like, it is better to like select from another category, right? I think this patient is anyway having flashbacks like uh, as a nightmares, right? But in that case, I think better to go from another, like we can select from the another category like arousal symptoms like that. As example here, hypervigilance. We can think like that. Okay, but we are not 100% sure because these hypervigilance and the flashbacks both are correct. I don't know why, if it is a mistake or not. I think sometimes this can be in one category, hypervigilance and flashback. We can't, like, it's very hard to select one from these two, hypervigilance and the flashback, right? What do you think? Yes, both doctor, yeah, that's the problem. But if they have given these like both in the scenario, so like if because nightmares and flashbacks are both in same category, in that in because of that only we can think like selecting something else in another category that can help to diagnose, right? We can think like that, but it is not 100% sure. Okay. Yeah. Yeah, that's why I'm telling that's not the proper answer because we don't know the stem properly. Stem should be like more powerful, right? This is like a very big stem. So in that case, what is this? Mm-hmm. Yeah, doctor. That's why I also add this DSM-5 criteria. So in that case, if we got this both, we can just think about what are the categories in the STEM. Then we can think it's better to get something else from another category, right? Like that. But it is not 100% sure. But sometimes this hypervigilance and flashback can be in the as in one option. Okay, so think like that. Okay, yeah, yeah. Okay, so that's how we have to think because this question is not complete, right? Yeah. Okay, so there's another question. Okay, another question. This is a controversial question. That's why also I'm telling these questions are like weird because in day one, day two, we got just lactation mastitis and just ask the treatment. Okay, say another scenario. The questions still are same, but they have changed something in the question. Okay, let's do the next question. So for the post traumatic this previous question, please remember uh, remember that concept. But I think the answer should be like hypergenous and flashback in the same option. But we don't know because recorder gave us like this. Okay. Okay, so next question is a breastfeeding woman present with mastitis. She is not allergic to penicillin. On examination, the breast is tender and swollen with regional lymphadenopathy. There is no fluctuant mass or no evidence of abscess. She is unable to tolerate oral flucloxacillin. So, what is the most appropriate next management? IV flucloxa, oral cephalexin. What do you think? What do you think? What about other doctors? Mm. Okay. Here's the Okay, again, we will go through this lactational mustard. We already discussed this by word in previous recall classes, but I need to go through it again because let's see why. The management of lactational mastitis. For all patients with lactational mastitis, the key aspect management are ensuring adequate milk drainage, rest, and minimizing inflammation. Like application of the heat, warm compression before free feeding, and cold pack after. Avoid pressure on the breast, pain relief by paracetamol, ibuprofen, or whatever. Okay. Then, for patients with symptoms that have not resolved after 24 to 48 hours of onset, start antibiotic therapy while continuing the other key aspects of the management. If the patient is presenting with systemic symptoms or patients after conservative management not improving, we have to think about antibiotic. Okay. At this stage, antibiotic therapy is most important to prevent the abscess formation. Consider offering the patient a delayed prescription for antibiotic therapy. During the first consultation, okay, with a clear instruction on when to start antibiotic. Example, in 24 to 48 hours, if symptoms does not resolve. Then oral antibiotic therapy is adequate for most patients with lactational mastitis and only use IV therapy for patients who are unable to tolerate and absorb oral therapy with extensive erythema or with symptoms that not resolved or improved after using therapy, oral therapy. And so, now what do you think? What do you think about the treatment? Is it still oral or we have to think about IV? What do you think? What do you think? Is it oral or IV? What do you think?